Yes, it's recording now, Sarah.
Okay, great, thanks. All right, so let's go back to the presentation. Okay, so just a little bit about my background. I'm a clinical psychologist. I first started working in this area when Philip Kramer, who's a neurologist, started sending me patients and initially just said, can you, they've got all these symptoms, but I don't think there's anything wrong with them. Can you try and teach them relaxation? And I did progressive muscle relaxation and tried to sort of reduce arousal. It made absolutely no difference. But over time, I started working out sort of alternative approaches that started being effective. And then this was sort of in around 2000. And then literature from overseas was coming in and sort of making sense of it. It actually started understanding a little bit more about the condition. And since then, I guess because I've been seeing so many of these patients, I've sort of come to understand what's going on. And hopefully some of the tools that I'll be passing on today will be useful for you. I know some of you are not necessarily psychologists. In fact, the majority of you aren't, but hopefully you can still do things from today's session that'll give you, it'll still give you tools to be able to help these patients to some degree. So first of all, I'm going to talk very briefly about the actual problem and what we're dealing with. So we know that dizziness is very common. We see it's seen a lot in primary care, in other words, with GPs. I was actually speaking to a GP friend yesterday when we went for a walk, and then I mentioned I was doing this presentation, and she said, oh, I've got so many dizzy people. I didn't know that, that you can do something about this. So it's also often not fully understood. And I think there's still a lot of people, particularly in primary care, who don't understand that dizziness can be psychophysiological and that there's a link and that it can be treated. So we see, obviously you see a lot of it in neurology clinics and ENT clinics, and also just in the general population. We know that there are many causes, so some of them have to do with inner ear, and that's benign positional vertigo and Meniere's disease and vestibular neuritis, etc. We know that some of it's neurological, including vestibular migraine, stroke, brain tumour, MS. And there are all sorts of other reasons for dizziness, including postural hypertension, medication side effects, arrhythmia, whiplash, etc. I just saw someone I've seen someone in the past who developed dizziness after waking up after anaesthetic from prostate surgery, and he was dizzy, and then that sort of switched on the syndrome. But we know that psychophysiological dizziness is also very common, and sometimes exists on its own, and sometimes it actually accompanies these other symptoms. So what is psychophysiological dizziness? It's, well, a little bit about the background. It's one of the most common causes of dizziness in Neurology Centre. By the way, Jeffrey Starb, one of the real key researchers in psychophysiological dizziness, he's written a number of papers. I think a couple of them I actually sent to you, but I can send you a whole lot of others, because he's a psychiatrist who's very interested in this phenomenon, and he's written a lot about this issue. It accounts for about 15 to 20% of all patient presentations. Patients followed for 3 to 12 months after an acute vestibular event, and usually we're talking about rotational vertigo. So about a quarter of them will develop ongoing dizziness, persistent dizziness, even after the vertigo has stopped. We know that there's a strong relationship between anxiety and dizziness. There's a well-established association. We know that anxious patients are much more likely to experience dizziness. But on the other hand, also patients with pre-existing mental illness are much more likely to develop long-term dizziness following a neurological event. And many patients that we see have a combination of both an anxiety disorder and also a physical disorder that is related to vertigo or dizziness. We know that anxiety changes the way that the brain works. When we're in an anxious state, we get amygdala activation, and that changes neural activity in the brain. and that also in turn affects physiology. Anxiety is not something that stops at the neck. Anxiety is very physical. So when we're in an anxious state, we get a whole series of physical symptoms, generally referred to as fight or flight, and I'm sure everyone here is familiar with the fight or flight syndrome. But when we explain anxiety to patients, most people explain it in terms of fight or flight, but in fact most of the patients that you see are not in fight or flight. They're actually more in a vigilance state, in a state of vigilance. So fight or flight is more associated with that rapid shallow breathing, pounding heart, increase in blood pressure, increase in oxygen consumption, etc. But the patients that we see, particularly patients with this syndrome, in fact with most anxiety disorders, much of the time are in a state of nervous arousal. So those of you who are familiar with the DASS is one of the most common screening instruments that are used by psychologists. They score highly on the stress subscale. So in the DASS, we've got 3 subscales. We've got the depression subscale, we've got the anxiety subscale, which measures fight or flight response, and we've got the stress subscale. And the stress subscale really is a misnomer. It really should be called nervousness, because that's how people describe themselves. They will say, I find it hard to wind down, I find it hard to relax, I feel like I'm using a lot of nervous energy, I find it hard to let go, etc. And in a sense, the brain is in a state of preparedness. So it's not in full-blown fight or flight, but it's constantly vigilant, and it just doesn't feel safe to relax or to switch off amygdala activation. It's interesting when you look at the Beck Anxiety Inventory, which is one of the more common instruments, or classically being one of the main instruments that historically has been used for measuring anxiety. Have a look at the number of somatic symptoms on the Beck Anxiety Inventory, and you notice that about 2/3 of the items on the inventory refer to physical symptoms. And I guess that's something we need to be aware of, and also something to remind our patients. Anxious people somatize. And much of the time when you're seeing people with anxiety, you're also going to be seeing people who have physical symptoms, other physical symptoms, of which dizziness and lightheadedness is one of the common ones. And we know that there are a whole lot of other common somatic symptoms. So when you see patients, the sort of common things that we see, things like fatigue. And in fact, by the way, people who are in that constantly anxious state are exhausted a lot of the time. Anxiety is physically exhausting. It uses a lot of energy. So often they'll complain about tiredness. They may have unsteadiness, muscle tension, or pain, twitches, headaches, neck pain. Neck pain is very common, and a lot of patients actually believe that their dizziness is coming from their neck. And I mean, sometimes it may be, but sometimes it's also because when people are anxious, there's a lot of tension in the neck and around the trapezes, and they end up with neck pain, nausea, diarrhea, and also problems with the jaw or TMJ. They're also very commonly experiencing medically unexplained symptoms like irritable bowel syndrome, fibromyalgia. They often, they start often with dizziness, and over time they might develop migraines or severe headaches, non-cardiac chest pain, etc. And as you know, often these people end up in emergency in hospitals because they're worried about physical symptoms. By the way, please feel free at any time to unmute yourself and just to call out a question. I'm very happy to take questions at any time, or if you want to make comments, or if you want to reflect on your own experiences, please feel free to do so. So the problem with this is, and with a lot of somatic symptoms, is that they're self-perpetuating. So anxiety focuses attention on threat. When we are anxious, we pay attention to threat. Most of the anxious patients that we see are paying attention to external threat. So typically for someone with generalized anxiety disorder or social anxiety or phobias, are paying attention to things going on outside of themselves, and it might be worrying about children or finances or work-related stresses, etc. But with somatic conditions, the threat is inside one's own body. And so people start to pay attention to the threat that they're perceiving inside their own body, and it's normally some sort of physical discomfort. Internal sensations become a source of threat, and focusing on those internal sensations perpetuates anxiety, and it perpetuates the somatic symptoms. So the more you pay attention to something, the more that feels not right, the more it perpetuates perceptions of threat. So the syndrome and the name and the criteria have evolved. So when I first started working in this area, it was called phobic postural vertigo, and there was a very vague definition of what we now call PPPD. And then it was later called chronic subjective dizziness, and Starb, and I sent you that article by Starb, which really, was defining, and it started talking about what we're seeing. And I remember, I think Michael Halmagi sent me this article by Starb, and I couldn't sleep that night. I was so excited because for the first time there was someone who actually could define what was going on. So our understanding of this is still very new and still evolving. And in 2014 it was finally labelled persistent postural perceptual dizziness. That was as a result of submissions from all around the world to identify key identifying features, and there was a new consensus criteria established, and now we call it PPPD, which is sort of a mouthful, especially if you're trying to sort of describe the actual full name. At this stage, PPPD is only defined in the ICD-11, which is not that widely used in Australia, more widely used in a lot of European countries, but it's defined as dizziness, rocking, swaying or unsteadiness, but non-spinning vertigo on most days for at least 3 months. Symptoms last for prolonged periods but may wax and wane. Symptoms often occur without provocation but exacerbated by upright posture, active or motion stimuli. Symptoms are worse with exposure to complex patterns or motion-rich environments. Oh, sorry, I just meant to admit someone, and instead of admitting them, I must have closed.
I haven't booked it yet, but I plan to. End of January.
Oh, sorry? I didn't hear that. Okay, so symptoms and cause significant distress or functional impairment. At the moment, the definition that we have, the definition that we have in the DSM it's much more vague. It's just called somatic symptom disorder, and it's not specific to dizziness. So that includes just any sort of somatic symptoms that are distressing or result in significant disruption in daily life, persistent thoughts and high levels of anxiety about the health symptoms. So this may also include pain syndromes. It may also include all sorts of other physical symptoms, excess time and energy focusing on symptoms, and then it may also include things like bowel syndromes, diarrhea, etc. And organic disorder may be present in combination with the actual somatic symptoms, but the key thing is that there's a lot of focus and preoccupation with it. And just wanted to briefly distinguish it from illness anxiety disorder. Illness anxiety disorder used to be called what? Does anyone know what it, in the previous iteration of the DSM, in the DSM-5, illness anxiety disorder was called? Anyone know?
Somatization disorder, was it?
Actually, no.
No.
The somatic symptom disorder has evolved from somatization.
Okay.
This is just hypochondriasis. So hypochondriasis no longer exists as a clinical term, thank God, because there's so much pejorative associations associated with it. But this is what illness anxiety disorder is, and the difference is that there's a preoccupation with having serious illness, but there's minimal or absent somatic symptoms. So a lot of people that we will see with dizziness also have coexisting illness anxiety disorder. Not everybody, but the ones that have illness anxiety disorder are the ones that are worried that they might have some serious life-threatening illness and something serious might be happening. The initial trigger, so this condition starts with initial trigger. It usually begins with, in fact, I reckon about 80 to 90% probably starts with vertigo. And I think vertigo is reasonably traumatizing or distressing, particularly for people who are already high on trait anxiety. But it may begin with other events, unsteadiness, dizziness, or anything that causes disruption to balance. And it might be due to, the typical things that we see, but also it can sometimes start with panic attack, anxiety, or disassociation. I do occasionally see people with no history of vertigo, but it seems to have just started because they've always been anxious, and they might say, look, I've always been dizzy. I remember having dizziness for 20 years, but just more recently it's become worse and worse. And sometimes it's an acute medical event like an adverse drug reaction, arrhythmia, postural hypertension, etc. One of Miriam's patients I've seen who the symptoms started with a car accident. Miriam, I don't know if you know who I'm talking about, but actually interestingly, so she's actually, since the car accident, she's been pretty disabled and very unable to work as a teacher. But actually, interestingly, when I talked to her, I found out that she actually has had vertigo episodes, rotational vertigo, in the past. So I just wondered whether that was a contributing factor. So they have the initial trigger. Those people who are who are highly anxious are more likely to become vigilant to the symptoms. There are also then interactions between psychological and neurological or central nervous system factors. We don't fully understand the physiological things, but we know that attention to internal sensations maintains the feelings of dizziness and balance. In other words, the more they focus on it, the more it sort of maintains the problem. A lot of these people have comorbidities, and they have, either neurological, physiological, but sometimes other serious health problems. And the ones that do have that combination of medical and physical, psychological and medical conditions are more symptomatic and are more likely to be impaired. With psychiatric comorbidities are the rule rather than the exception. It's rare that you find somebody that doesn't have a comorbidity. The most common ones that we tend to see are generalized anxiety disorder. So these are people who are already focusing on threat and very vigilant to threat generally, tending to worry or focus on possible threats in the environment. Illness anxiety disorder, what we previously called hypochondriasis. A lot of them also have depression or have a history of depression. And when I've talked about generalized anxiety disorder, people sort of assume that, oh, well, if you've got a lot of generalized anxiety. But by the way, with people with generalized anxiety disorder, about 5 or 6 times more likely to experience episodes of depression than the rest of the population. And when I've asked people, what do you think is going on there, they sort of assume that it's because of the, they worry so much they kind of get themselves into a state and get depressed. But there's also, there's research suggesting there's actually a higher order factor which accounts for both generalized anxiety disorder and depression. Does anyone want to have a go at guessing what that higher order factor is? Well, it's neuroticism. So people who are high in neuroticism are more likely to develop generalized anxiety disorder or anxiety disorders more generally. They're also at higher risk of depression. And once again, neuroticism is a really unfortunate term, and I think there's a need for changing that term to sort of destigmatize it. But the reality is, many of us are wired to be more reactive. So neuroticism is a tendency towards rapid reactivity. It's partly physiological, high autonomic arousability, slow habituation. It's also a tendency towards higher emotionality. So tendency to become more anxious, but also perhaps more depressed, more angry, more upset. Generally, things press our buttons more easily. The other thing is obsessional personality style. We know people who tend to be more obsessional. They may have, in some cases, they have obsessive compulsive disorder, but quite often it's just that personality style that is obsessional and that finds it hard to let go. And sometimes I sort of talk about it's like constantly picking a scab. It's not letting things go because the need for things to be totally resolved before they can let it go. And in some of the research literature, some of the early research literature, Brandt observed that people who are more prone to this condition have a more obsessive compulsive personality style, labile affect being, again, reactivity, which today we'd call neuroticism. Starb also found neuroticism and behavioural inhibition. Behavioural inhibition tends to be anxiety that's not necessarily associated with neuroticism, so it's those of us who are shy or perhaps more introverted, but tending to kind of be more self-conscious. And a subsequent study looking at personality style also found anxiety and introverted personality style. So you can sort of see the same traits coming up in various studies. The common symptoms that I've observed: episodic dizziness, lightheadedness or rocking, feelings of imbalance, unsteadiness or veering ground, feels unstable. Often they'll get dizzy when they move their head. People often describe fullness or heaviness or cloudiness in the head. Hypersensitivity to motion stimuli, so yeah, shopping centres, supermarkets, scrolling on the computer screen, those sort of things will trigger it. A lot of them complain about visual disturbances, and I noticed that wasn't in the ICD-11 criteria, but I would say, you know, in my experience, about more than half talk about, you know, things going out of focus, and they go and get their eyes checked and their eyes are okay, but they seem to, you know, still very frequently. And maybe that's part of the, you know, vestibular migraine or some other symptom, but some other medical condition, but it just seems to come up very commonly. And neurological neurological tests are normal, or they don't account for the level of symptoms. So even with people with Meniere's disease, who obviously have very severe rotational vertigo and have very severe symptoms, they often develop this sort of ongoing dizziness between episodes of vertigo, which still isn't normally a part of classic Meniere's. So there've been a few studies. At the moment, some of the early studies combined vestibular rehabilitation with CBT and were largely behaviour therapy. There's been a few studies, and I can sort of send you a paper. And in fact, I think I've attached one of my the paper that we produced, which describes some of the earlier studies, CBT studies, and none of the findings were outstanding, but there is sort of emerging evidence that you can do something about it. We did a study, this was with Philip Kramer and Alison Marnie, in 2012, where we evaluated 3 sessions of CBT, but looking at physical symptoms, disability avoidance behaviours and distress using the DASS. At that stage, I think we knew a lot less about how to treat this condition. And one of the things we noticed is when we gave people a flyer, when we gave people an explanation, when we gave people reassurance, we got them to do behavioural exposure, get out there, go to shopping, you know, do some of the things, you know, stop the avoidance, do some exercise. But that seemed to be improving symptoms. And in fact, when we did this study, we did find a significant improvement. I'll show you in a minute. The only thing, our study got criticised a lot, and reasonably so, but we created our own measure based on the symptoms we observed, which unfortunately wasn't validated. And the reason why we created our own measure is because there was nothing really useful available. There's one measure called the vertigo symptom scale, which other studies have used, but it actually includes measures of rotational vertigo, which are completely irrelevant to PPPD. So this is, I've included this measure in the email that I've sent you. So I still find it a really useful instrument to use baseline. So when I first see them for the first time, I get them to fill in this questionnaire, and at the end of treatment, I get them to fill it in again, or even when I'm writing to GP, I get them to fill in again. It's very sensitive to changes in PPD symptoms. So I still reckon it's a good measure, but it does need validation. And as I said, you've got that in the email that I sent you. So we found that there was a significant reduction in symptoms on the DSI, disability. There was also a reduction in disability, a really significant reduction in disability on the dizziness handicap inventory. Their avoidance and safety behaviours reduced. We actually did get a reduction in anxiety and depression, but so did the control group, unfortunately. So there was no significant improvement. But we also did a 6-month follow-up study which showed that those improvements were sustained. And I think, as far as I know, we're the only, this is the only bit of research to date that's actually done a follow-up study. So the treatment model, how do we actually treat these patients? So it's based on, and in fact, one of the things that I started noticing is when I first started treating these patients is these patients are actually responding in exactly the same way as panic disorder patients, or there's a lot of similarities. So the model for treating panic disorder, sorry, I should have said panic disorder. So the model for treating panic disorder, which was described by Paul Salkowski, is you get this trigger, and the trigger might be they're in the supermarket, and they're sort of remembering that this is where I previously had a panic attack, and so their anxiety goes up. As their anxiety goes up, they start getting a whole lot of physical symptoms. When they start getting physical symptoms, they start getting catastrophic thoughts. Oh my God, I'm going to collapse. I'm going to panic. I'm going to make a fool of myself. And then, of course, once they have catastrophic thoughts, it increases fear. It maintains somatic symptoms, and you get that self-perpetuating cycle, which happens in panic disorder. And again, if we look at how all of this works, with panic disorder, the initial panic attacks are initiated by either stress or some sort of physical stimulus. In some cases, it can be illicit drugs or illness or caffeine. But once they have a panic attack, the disorder is maintained by fear of further panic attacks. In other words, the hypervigilance to their own body and internal sensations keeps them in an anxious state and keeps them symptomatic, and it becomes a self-perpetuating cycle. So coming back to personality, we know that people who are high trait anxiety or neuroticism experience high threat perceptions and are more likely to experience body symptoms as dangerous. And body sensations are amplified, first of all, just by paying attention. And secondly, people high in neuroticism experience higher levels of autonomic nervous system activation, endocrine activity, and hyperventilation. So they're more likely to become aroused, they're more likely to therefore become symptomatic and experience somatic symptoms. Just a little bit about assessment, useful questionnaires. The dizziness symptom inventory, which is the one I just mentioned, I think is useful just to see how they score on some of the key features. The DAS, which I'd say all psychologists use, but it might be useful even if you're not a psychologist. You can just download it from free from the internet, and it measures anxiety, depression, and stress. The stress subscale is the one I always look at because that's the one that indicates high levels of the vigilance response, that nervous activity. And also the dizziness handicap inventory is quite useful. I can't remember if I sent that to you. I can send it to you if you don't have it. And that just measures the amount of how disabled they are as a result of the dizziness. Initial questions, what are initially I just get them to fill out the dizziness symptom inventory. Important question, how did it start? When did it start? What were the initial symptoms when you first experienced it? And are they the same now or have they changed? So most people say it started, whatever, in August last year, and I've had it all the time since. But when you actually look closely, you notice that initially the symptoms were vertigo. Now they're not vertigo anymore. Now they're dizzy, woozy, unsteady, unbalanced sensations. So they've actually changed. They often will say, well, initially the symptoms were like this, but now they're like that. Medical tests or outcomes. What did the medical tests say? What's been the feedback from your medical practitioners? Do you think they might have missed something? So patients, particularly with illness anxiety disorder, often worry that maybe they've missed something. Everyone tells me I'm okay, but I still get these, these awful symptoms, and I'm just not convinced. And one of the questions I often ask is, what do you think is causing the symptoms? And quite often they'll say things like, well, I just have to believe that it's anxiety. But that actually tells you that, you know, if someone's saying, I have to believe, it's actually saying that part of them still believe that there's something else going on. And sometimes if I get an ambivalence response, so some people will say, I absolutely know that this is not medical, I absolutely know it's anxiety and it totally makes sense. So once we've got that, we can just, you know, that's useful information, we can move on. But a lot of them will say, yeah, I'm pretty sure that there's nothing wrong. So I'll always ask for clarification and say something like, well, the majority of patients I see say, look, I know it's probably not serious, but there's a little part of me that still worries that it might be. Is that true for you? And when I ask that question, I very often get a yes, you know, they're still worried about it. So that's actually useful information, because it actually means that we need to work a little bit more on demonstrating that anxiety is playing a role here. And I'll talk to you about how to do that shortly. So we get their history, we get their history. I don't go too strongly into family history of mental illness, even though I probably would by the second session, but not immediately, because they often get defensive. You think it's just mental illness. So just ask, have you seen any other psychologists, and have you had any previous psychological treatment? One of the things I found is quite often they have seen other psychologists, but depending on how aware the psychologist is, they don't always get the help that they need, which is one of the reasons I'm so keen to get this training out to other psychologists, and also not even all neurologists are fully au fait with this area. So this is just sort of standard questioning that we would do for any anxiety disorder. What do you do to keep yourself safe? Is there anything you do to prevent the symptoms? And they might say, I'm very careful with moving my head. I don't move my head very much. Or I'm sort of very cautious with certain things. Is there anything you do to try and stop the symptoms when they arise? And sometimes they'll say, oh yeah, I go straight to bed, or I lie down straight away, or or they might say, I try to meditate or whatever. Is there anything you do anything you avoid now because of symptoms? And avoidance is really important. That information is really important, because we want to know if they're avoiding things, that's going to give us information for an exposure schedule further down the track. We assess the current triggers. Is there anything, are some things more likely to trigger the symptoms or increase the severity? And there's a whole lot of things that people might say. Busy public places. Some people just say standing. When I stand up, it's worse. Walking, restaurants, being with people. And often it's the fear is, if I'm with people, because I normally have to really concentrate to stop these symptoms or to control my symptoms, and being with people feels like it's a distraction. It feels like I can't concentrate on my symptoms, or I worry that they'll notice, so I get more symptoms. Moving my head, standing in queues. For a lot of people, queues are really awful, because they feel a little bit trapped. They have to, wait until the cues move. So we try and identify what is the fear, what is it that they're scared of about these symptoms. And I think initially about 50% will say serious medical illness. They still worry that there's something that hasn't been identified. But other people will say, I'll fall over, I'll draw attention to myself, people will notice, people will think I'm mad, or this means I have a mental illness, it's not normal, I'll never recover. Fear about disability, I won't be able to work, I'll be completely disabled. And in my experience, often the fear of the medical illness is the initial thing, and then later it becomes, what if I never get over this? What if I become completely disabled? So, but all of these other things come up as well. Are there any questions? I'm sort of conscious that I'm sort of talking a lot. Please feel free to unmute yourself and ask a question. So just pause.
I'll have a question.
Mm-hmm.
How do you deal with the patients who have an ongoing actual vestibular disorder, who have psychological issues on top of that?
Yeah, I guess we need to explain that to them, that there is a vestibular disorder, but this particular disorder, explain the common symptoms of this particular disorder. So normally people with, say, vestibular migraine or BPPV will have episodes of rotational vertigo, but you compare your unanxious people with this vestibular disorder and the ones that also have a lot of anxiety. And if there are additional symptoms, then that would suggest that there's probably psychological factors are also contributing to it. Okay. Good question, actually. Any other questions?
Ali, I just remember a session that Sarah and I shared. I had tested him about 10 times on the Omniax for BPV, and he had these ongoing symptoms. And he started seeing Sarah, felt a lot of benefit. And then about 6 months down the track, I get a phone call from Sarah saying, or an email saying, this time, Miriam, it's really BPV. And I say, send him across, and sure enough, it's BPV. And he understood that. He was very grateful for the treatment, and he went back to Sarah after that.
Yeah. So I guess, you know, and maybe I don't probably have enough understanding of all the typical physical symptoms of the vestibular conditions, but my understanding is that one of the most unpleasant physical aspects is the rotational vertigo. Is that right? That's sort of the main thing. And if they're getting a lot of woozy, unsteady, unbalanced, the ground's moving under their feet, head feels full, all of those, that's much more typical of PPPD.
I have a question as well. May I, Gülden?
Sure, please do.
I was going to ask how many of your patients turn out to have little BPV, let's say it like that, one torsional nystagmus on the distal park, because I've seen lots of patients coming with anxiety. When you do really, really detailed and focused neurological examination, then you need to do one maneuver more. So I wonder, this rotational vertigo could be some little, you know, BPV or lateral canal, not posterior, but, and I work with a psychiatrist friend with those patients. I mean, most of them are vestibular migraine. And when we suggest them vestibular rehabilitation, my psychiatrist friends said that it looks like a behavioral therapy for them, and it works very well because there is existing anxiety, personality disorder, which are very common with vestibular migraine patients than migraine-only patients.
Yeah, so two things that you mentioned there, which are really both very relevant. One is it is easy to miss, especially for patients very anxious. It is sometimes easier to miss that they also have a component of BPPV, which might be contributing. So yes, that, you know, we do need thorough assessment, and I think that is an ongoing risk. The second thing that you said was vestibular rehabilitation can be useful because it is like a behaviour therapy, and we agree with that. In fact, I remember having a discussion with Miriam at one stage and suggested, you know, and we were talking about even possibly doing a study where you do a sham vestibular rehabilitation treatment versus a real one, you know, where you randomise and see if there is a difference. Because I totally agree. I think anything that encourages, I mean, I guess with this therapy, we always encourage exercise, get out there physically, sort of do things and so on. Anything that encourages people to, you know, to drop avoidance and to get out there is useful. And so, yeah, I agree. I think a lot of vestibular rehabilitation is...
So we just finished a study. We are about to submit vestibular rehabilitation in vestibular migraine patients, but we divided into groups: DIH, dizziness handicap inventory high, and agoraphobic panic symptoms. So agoraphobic panic symptoms high patients also had benefited from the low score patients, nearly same level. So vestibular rehabilitation works very well.
Yeah, but it might be more costly than just getting them to go for a walk every day.
Yeah, you are right, but you are not sure about the patients are doing. I mean, in Australia, people are very prone to be, you know, athletic type exercise, and I am based in Turkey, so we have to encourage people to go out and do exercise. I agree with you.
So maybe you need to judge the patient. If the only way you can get them to exercise is doing some vestibular rehabilitation, that might be the way. Okay, yeah, thank you. They're all terrific questions, really appreciate it. Okay, you've got, so, and maybe this is sort of coming back to a question that was asked a little bit earlier. How do you know if it's psychological, if psychological factors are playing a role, or if really, if you're dealing mainly with, you know, the symptoms of a, you know, vestibular or central nervous system problem? I'm going to ask you what questions you would ask. What would be the way that you would find out or work out whether psychological factors are playing a role? How do you establish that? Any ideas?
So Sarah, sometimes the patients come clearly with a history and an examination that fit very neatly with the syndrome, or very neatly with a previously described syndrome. There are then many other instances they fit with nothing. And I just openly tell them, look, this doesn't exactly fit with anything that I know of. And many of them, when they hear that, are accepting of that. But then equally, there are times when they very neatly fit with anxiety as well.
Yeah. So partly it can be a process of elimination, you know, that they don't fit any other criteria, plus they seem anxious, so they sort of, they appear very much to fit the protocol. But there are questions actually that you can ask to get a little bit more clues about that. And the key is situational variation. And that is, are the symptoms worse in some situations? Are the symptoms worse when they're outside of home, but when they're at home, they're not too bad? Busy public areas, I guess, can be, you know, maybe there may be neurological factors for that, but in social situations, and if you're with people that you don't know very well, or if you're at a meeting and you're getting more symptoms then, but when you're with your family, you have very few symptoms. So you're getting that situation, you know, it's all about safe versus unsafe. That's what we're trying to establish. In large open spaces, and for people who, you know, who are more prone to sort of feel anxious when there's no walls or nothing to hold on to, on certain days of the week. So you'll get some people who say my symptoms are worse on weekends, or they're better on weekends, they're worse during the week. So, you know, so you can sort of say, well, what do you think's going on there? You know, this is a condition that only, you know, that seems to get worse on a Monday, or better on other days. And some of them will say, look, when I'm rushing or when I'm stressed. Some people will say, when I'm stressed, I definitely get more symptoms. The other thing is that, are the symptoms better in some situations? And interestingly, a lot of people, not everyone, because the ones that are really anxious about driving, especially someone who's had a car accident or who's always been a nervous driver, will not relate to this. But the majority of people I see, when I ask them, you know, when you're driving, what, you know, the symptoms better or worse, most people say the symptoms are better. And the question is, what is going on there? Why are they having less symptoms when they're driving?
I think that relates to the speed limits. You see, constant velocity is a comfort situation for the vestibular system. You have to drive at 50. That's as good as staying still. What does everyone else think?
Stopping and starting is worse.
Yeah.
Accelerating.
I have a different theory. Yeah. And you might be right. I'm not certain about this, but my theory is it's the role of attention. You are so used to, you know, you've gotten into your car, most of us, thousands or hundreds of thousands of times. You get in the car, the first thing you do is you pay attention to the road. It's automatic. And you pay attention to something external to yourself, you are less vigilant to what's going on. So that, you know, that's your, and I'll talk a little bit about, you know, the role of attention. But it's interesting that when people are driving, and actually if you really want to put it to the test, get them to be passengers, because a lot of people will say, when I'm a passenger, I'm still dizzy, but when I'm a driver, I'm not. So there's a good experiment that you can use to test, to work out, you know, whether it's the movement or whether it's the concentration to the external that affects this. And some will say, look, when I'm totally absorbed in activity, or I was on that conference call, I completely, it went. And some people will say, I went on this, I went for 2 weeks on this holiday to Noosa. I didn't have any symptoms, but as soon as I came back, I could feel the symptoms coming back as I was driving back from the airport. So if you're getting symptoms here, but you're not getting symptoms there, that usually suggests psychological factors are playing a role. Following a positive test result, so some people will have an MRI and it all comes back well and good, and they've had all the results, and the results are good, and suddenly they say, I feel so much better. The symptoms have diminished. And you say, well, what do you think might be going on there? And even following an explanation and reassurance, and even after a couple of drinks. So they have a bit of alcohol and they say, my symptoms are a lot better. So what do you think is going on there? I also have a theory about standing up, that we feel safe when we're sitting. You think about it. When you're sitting in your chair, you feel safe. As soon as you stand up, what's the difference? Your head is in exactly the same position, except it's, what has changed? Altitude. And when you're standing up and you've got altitude, you look down, you're less safe. You're more safe sitting down. You're more safe lying down. And I think the reason why a lot of people report being more dizzy when they're standing up is partly because their brain is also telling them that they're less safe. Some patients feel defensive. Occasionally get people who say, look, everyone says there's nothing wrong, but I feel awful. And some are skeptical of the anxiety explanation. They don't see themselves as anxious, or they don't believe that it could cause such physical symptoms. But for people who say, look, I'm not anxious, I actually just ask them to close their eyes and just do a very brief mindful awareness exercise. Just close your eyes. What do you notice? What do you notice what's going on in the back of your mind? Now turn to your body. What do you notice? What's happening in your body? And then very often they'll say, oh yeah, there's tension, there's tightness. So just getting them to stop and observe can actually help answer that question, or rebut that issue about, but I'm not anxious. But they have a fear, obviously, that serious symptoms might, or serious illness might be ignored. But we also do need to recognise that it's not always purely PPPD, that sometimes they are experiencing symptoms associated with the actual physical condition. So treatment. So how do we go about treatment? Well, first of all, it's the explanation. And one of the first things I always ask is, how much of the time is this on your mind? Including, I say, how much of the time is it either on the front of your mind or the back of your mind? And most people will say 100%. So it's either on the back of the mind or in the front of the mind. So, and how much of your attention is in this conversation? And where is the rest of the attention? When you are in an anxious state, your attention is divided. It is very rare that you get 100% of your attention in this conversation unless the information is so salient and riveting that everything else becomes irrelevant. So most of the people we see, their attention is all over the place. And even when I say how much of your attention is in this conversation, they'll say 50% or 60%. So where's the rest of it? Well, I'm just thinking about all these other things. What is the effect? What is the effect of thinking about or focusing on something all the time? You keep paying attention to something all the time. What do you think happens to that issue? It gets magnified. You get more preoccupied with it. We can do experiments in session with attention manipulation. So I always ask them to stand up because you tend to be a little bit more symptomatic when they're standing. Can you bring on the symptoms for me, which they're horrified at the idea. So I say, just move your head side to side. And if that doesn't do it, just walk around in a little circle. We want to try and get a bit of dizziness. And once they're in that dizziness state, just tell me, on a scale of 0 to 10, how bad is that? And then distract with questions and then re-rate the intensity. So I might ask, the typical questions I ask is, what did you have for dinner last night? What did you have for dinner the night before? What about the night before? What day of the week was it? And what did you have the night before? It requires a lot of cognitive resources to think about something else. And therefore, that actually is really helpful in terms of reducing attention to current body experience. Or I just get them to stand up. So when they first stand up, they might, how intense are your symptoms? They might be 7 or 8. And then I'll ask those questions, or I'll ask, what did you buy in the supermarket last time you were there? Can you remember what you bought the time before that? Or do you use social media? And if they use social media, what did you see on Facebook or Instagram or whatever today or yesterday or the day before? And again, it's things that require a lot of cognitive resources that take them completely out of the present moment experience. What's happened to your symptoms now? And so we're just testing the role of attention. And the other one I like is stand on one leg. And this is interesting for people who say the ground's moving and, you know, I sort of feel like, you know, I'm unbalanced, and I say stand on one leg, and they've usually got better balance than I have. And what happens to the symptoms now? Sometimes, not always, this is so variable, but some people will say their symptoms have reduced when they stand on one leg. So how do you make sense of that? You're telling me the ground feels unstable, but your symptoms are less when you're standing on one leg. And sometimes it's because they're using more cognitive resources to pay attention to balance. And the other thing I sometimes get people to do is just, you know, just focus on the sensations under your foot, the point at which the foot touches the ground. You can even do that as a mindfulness exercise where they're sort of getting out of their head and more into, you know, the furthest region away in their body. In session observations, you know, so sometimes they come, they turn up and they're sort of they're very symptomatic, and I sort of ask them early on, you know, it sounds like you're getting a lot of symptoms. On a scale of 0 to 10, can you give me a rating? And they might say it's an 8 or a 7 or whatever. Sometimes they come and they have no symptoms at the time, but quite often they'll have symptoms. And then we sort of talk and we chat, and hopefully I'll put them at ease. And then I say, yeah, by the way, what are your symptoms like now? And they say, oh, now they're, you know, they've gone down to a 3. And I say, oh, that's interesting. What do you think is going on there? And quite often they say, oh, well, I think it's because I feel more comfortable being here now. I sort of feel more comfortable with you. So you're saying that just feeling more comfortable, feeling more safe in this room has an effect on the symptoms themselves. So they're kind of observations you can make. Oh, yeah, and for some patients, I actually literally do this. And turn my back on the patient and say, how are your symptoms now? And for some patients, they actually say they're better. And this is particularly true with patients who have some social anxiety and they feel, you know, self-conscious, or they feel like they're being observed. So, you know, and occasionally I'll do the opposite and I'll get right in their face. I'll do this. And when I do that, they actually physically can feel more symptoms. So it's just playing around with the effects of threat and high threat, low threat. For patients who have a cautious gait, so some patients develop this sort of, I think it's called slippery ice gait. It's almost like they're walking on ice where they're being sort of very careful. And so I sort of get them, first of all, in session, I get them to just walk up and down the hallway, saying a tongue twister, like Peter Piper picked a peck of pickled peppers. And they're trying to focus on 2 things at one time. And initially, they're kind of like, they get really wobbly because they can't concentrate, because they're really trying to focus on keeping their walking safe. And the goal of this is, you know, stop paying attention to walking. Your walking will be okay. You know, as long as they don't have some balance disorder, and I always check with it, if they haven't got a balance disorder, you can walk, and it's time that you stop paying attention to it. So we practice that, and then I'll go for a walk with them in the street, engage in conversation, try and really distract them by engaging conversation, ask them about their work or their children or things that people are interested in, and then just ask how much of your attention is in this conversation. And can you give me 100% of your attention? So, and quite often when I ask how much is your attention in this conversation, they'll say 80%, but it's not 100%. They're not totally engaged. They're still monitoring. So let's see if we can give me 100%. And even sometimes I'll say, see if you can skip, and we'll sort of both skip, and just to kind of loosen up that gait so that they're not sort of being so cautious all the time. This is, I guess, where vestibular rehabilitation could be useful as well, but maybe we can just sort of get them to relax by just demonstrating that when they're not concentrating on trying to be steady, that they actually nevertheless remain steady. They don't fall, they don't sort of experience any sort of negative consequences. And occasionally I've gone to the supermarket with patients who kind of say, I get really bad dizziness in the supermarket. So we go to the supermarket and we experiment with exposure and distraction, and they invariably are very dizzy when I'm in the supermarket. So I get them to practice distraction, and I ask them some of those distracting questions like, you know, what are you going to make when you buy stuff? What are you planning to cook today? Or just even what did you have for dinner? You know, the usual. What emails did you receive in the last 24 hours? Can you remember who emailed you? And when they're distracted, the symptoms go down. So again, it's just demonstrating the effects of attention. And what is the role of attention? Can you see how attention is playing a role with this? This is just one other thing that is interesting. This is for patients who have very specific ideas about what's going on in their body, and they come in, and I had one client in particular, I'll call her Nadia, and she had a whole syndrome of dizziness, but very anxious, severe hyperacusis and tinnitus, and really severe noise, intensive noise sensitivity. And she was telling me about how she went to she was in Botanical Gardens, and she went to a cafe with a friend, and she had a terrible experience. There was some, you know, works going on, and you know, the noise was shocking, and her tinnitus was terrible, you know, and everything was just sort of terrible. It was the most awful, terrible experience. So I actually said, can we actually try and visualize that now? So very reluctantly, she visualized the whole thing again. And she's experiencing, you can see she's grimacing. And at the end of the session, you know, at the end of doing that, I said, you know, how was that? And she said, oh, it was terrible. And she's sort of a bit upset with me with putting her through all that again. And I said, so were you getting those symptoms because of the noise, or were you getting those symptoms because of what was going on within your mind? And that was kind of an aha moment for her, that it's not just the external environment, that there's a psychological aspect in this, and perhaps, you know, perhaps the actual resistance and the way that she's responding is also part of the problem. So sometimes just demonstrating that by just visualizing the thing that they believe is causing the problem can be useful. So the goal of treatment is to try and reduce hypervigilance, and basically key things that we do: psychoeducation, trying to address the particular things that the patient is worried about, exposure to feared situations, so getting them to do repeated exposure, build tolerance, and finally build tolerance for unpleasant sensations, and that's where the mindfulness stuff is useful. So psychoeducation, patient believes that maybe there's something serious going on. We want to provide an alternative low-threat explanation for the dizziness, and that includes formulation and sort of explanation for hypervigilance and the self-perpetuating cycle, and explaining the nature of anxiety. People often don't understand that anxiety is a very physical state. It's not just something, you know, it's not just something that stops at the neck. It affects the entire body, talking a little bit about somatization, and really reinforcing that the symptoms are real. They're not imagining the symptoms, but psychological factors may be triggers or maybe perpetuating the symptoms. One of the things, and this was with the study that we did in 2012, we gave them a flyer. I've since updated this flyer a few more times as we know a little bit more about it. I've emailed everybody this flyer, and for a lot of people, just getting the flyer, reading through it, being able to relate to it is a huge relief. And I think, Miriam, you can testify for that. You sort of said ever since they get the flyer. And again, it's just a plausible explanation, a safe explanation that they can relate to, with some strategies which most people find really helpful. So the flyer is something useful. We talk a little bit about the formulation, how it all started. So initially it started with a rotational vertigo, for example. They suddenly, you know, it can be a sort of a traumatizing event. They get very anxious and hypervigilant. And as they're anxious and aroused, they get a whole lot of physical symptoms, unsteadiness, headaches, fullness in the head. And because they're anxious, you get a whole lot of threat perceptions, such as, why is this happening? Am I going to get vertigo? Is it going to be a serious medical problem? How do I stop it? All these, you know, overanalyzing threat perceptions, which keep them in an anxious state, which keep them somatic, which keep them. So I explain this, and again, most patients really relate to this. It is in that flyer, but I always go through it with them anyway, because it actually makes so much sense and it is reassuring. And I said one of the things that we've got to do is we need to short circuit this ongoing cycle. So, you know, the therapy is about trying to reduce the anxiety and reduce the threat perceptions. So we want to try and address, first of all, fear of life-threatening illness, which is one of the most common threat perceptions. So we do that by just explaining the role of psychological factors. Are they playing a role? If the patient is saying, look, I get more symptoms outside of the home or at work or on weekdays or in social situations, and I get less symptoms when I'm at home or when I'm driving or when I'm distracted or absorbed in activity or conversation or when I'm on a holiday, that's pretty good evidence that psychological factors are playing a role. And so you ask them, so what's going on? When you focused on the symptoms, they got worse. And when you went on that conference call, this was just an example with a client who said, you know, I had really bad symptoms, but then I had to take this call and it was really important. And I completely forgot about my symptoms. You know what? They disappeared. So what do you think is going on there? Your symptoms diminished after our first session. Was that a coincidence? So actually, after one session where they get a good, plausible explanation, a formulation of what's going on, they usually leave feeling much better, and often they get no symptoms, and then by a week, you know, by the end of the week or whatever, they will have another. You know, very few people are cured after one session, but so they'll have another episode and suddenly they're anxious again and suddenly they're symptomatic again. And I say, but hang on, your symptoms, you say your symptoms diminished after the first session. How can that be? What do you think was going on there? You say you have less symptoms on the weekend and more symptoms on the day of work, if this is true. I mean, obviously it depends on the patient's formulation. So what do you think is going on there? And the other thing I say, neurological illness or cancer, symptoms progress over time. You've had the symptoms on and off for a year and it hasn't progressed. You know, why not? What do you think is going on there? And in fact, you know, the symptoms are better now than perhaps when I first started seeing you. So that doesn't make sense. Most neurological illnesses are progressive. And occasionally you'll see people, I'm not anxious, but I'm not anxious. I know what anxiety feels like and I don't have it. Usually when people say that, they're thinking of fight or flight syndrome. So they're thinking of anxiety as in, you know, the full-blown kind of physical arousal, panicky symptoms. And they also sometimes say my symptoms come out of the blue. I was relaxing, watching TV, etc. So there's not always that temporal association. And look, I can't always say what's going on there. It can be a physiological thing, or it can be something associated with a medical condition. But sometimes when they say I was just watching TV, the back of the mind is still hypervigilant. You know, small things can still trigger it. So it's not always physiological. Psychological factors still play a role. Sometimes people will say, but my symptoms are constant. You know, they're the same all the time. There's no variation. But again, I notice that when I question it, you will get, they do have variation. They do have better times and worse times. And just remember that many patients do have vestibular and medical conditions, plus they do also have the anxiety-related somatic symptoms. Eventually, I find that 2 or 3 sessions, or sometimes less, they suddenly realise they don't have a serious medical condition. And for some people, it's, oh, I'm so relieved, you know, that makes me feel much better. But for some people, if it's not, if it's anxiety, they feel worse or they feel distressed. And that's because, and they'll say things like, so it's all in my head, or anxiety means that I have mental illness, and some of them have had a history of mental illness, so it sort of means, oh, this is more mental illness. Now I'll never get rid of it, or people will find out and they'll think I'm crazy. So there's often threat perceptions when you actually demonstrate that it's not. I mean, in my experience, I'd say about 50 to 60% feel better when they realise it's just anxiety, but there would be about 40% who would actually be more anxious or not appeased by the fact that it is anxiety. So it's all about the meanings that we give to that experience. Other common threat perceptions, so people also worry I'll faint, I'll fall over, I'll draw attention to myself, people will think I'm drunk. I have a mental disorder, this means I'm defective, it's my fault, I'm doing this to myself, I'll never recover, it'll get worse, I won't be able to work or function. All of these can be disputed using Socratic questioning. I probably won't go into that now. For the people, for the psychologists that are here who would like to, who I'm happy to sort of supervise and talk a little bit more about these, I can talk to you a little bit more about how you can challenge these, just because I'm sort of conscious of time. But all of them can be sort of disputed. And by the way, it's very rare for people with dizziness and imbalance from PPPD to fall over. And in fact, I think I've very rarely seen it, that people do fall over. And also fainting. I don't think I've ever seen anyone who's fainted from PPPD, but that is a common fear. So how would you address these fears? People will notice they'll think I'm crazy, and that is a common fear. They'll think I'm drunk, or they'll think I'm crazy. How would you address these fears? This is where I'll open it up to you. Anyone? Any ideas?
I suppose you'd start asking them for evidence of when that has happened, if if something has occurred, and evidence that anything like that has occurred too. So start looking for evidence.
Yeah. So what is the evidence? Have you had any feedback? Has anyone said to you, "Are you okay?" And even if someone did notice, so the reality is, when they ask their friends, most people say, "No, I never noticed." If they actually do, so you can just do a behavioural experiment and ask. But even if someone did notice that they're veering, that is not normally associated with craziness. That can just be an imbalance problem, which most people, has very low social judgment associated with it. So, we can sort of dispute that in all sorts of ways. I will faint, I will fall over. The reality is you can say, look, I've seen, and in my case, I've seen, hundreds, probably, possibly more than hundreds of people, and I've never seen anyone who's actually fainted. It's very rare that people fall over. In fact, I haven't seen anyone who's fallen over because of it. I think it's plausible, especially amongst older people, but they may be fall over for other reasons anyway. And what if this never goes away? That tends to be the real sort of fear. Will this ever go away? Will it get better? And I think now, after seeing so many patients, I can say, can you guarantee this will go away? I can say, I can guarantee you will feel better than you feel now. So everybody gets better. For some people, the dizziness will come and go, but you will learn to live with that. For some people, you will completely recover. And even if people do have ongoing dizziness, you learn to live with it, so it's less of a problem. But my experience is most people that I see are better. And for some people, it will disappear. So this is where I would give a little bit of reassurance, because it is definitely treatable. One of the problems is they go on online with this dizziness thing, and there's a whole lot of horrendous stories online, and I think unfortunately a lot of people don't get good treatment, or they haven't seen, the understanding of this whole syndrome is still very young, and I just don't think there's enough people with expertise who know how to treat it. So you want to address their safety behaviours, and typically people with dizziness will stop exercising, or they'll sit down at every opportunity, or they avoid busy public places and social situations. So you want to get them to do some behavioural experiments or just do some monitoring. So I give them an exposure schedule. This is in your handouts, you would have received this, and you write down the exposure exercise in the left-hand column, and every time they do it, they record 3 things. And I'll show you a real one. This is one of Miriam's patients, and this is her exposure schedule. So she goes on the treadmill, she walks outside. This has been part of her exercise, just moving her head from side to side, standing up, driving. She's still very phobic about driving. Her symptoms actually really really sort of started when she had a car accident. Miriam, I don't know if you know who I'm talking about. But after that, the symptoms really ramped up, so she's still very nervous of driving, but she's very conscientious, and she does these exposure schedules, and it helps her to see that she's gradually getting better. Her symptoms were initially, and she still has good days and bad days, but I find this exposure schedule really useful. The other thing I want to talk about is mindfulness, and I think mindfulness has kind of been used in different ways, and I think some ways are more useful than others. So when you think about mindfulness, there is the old classic mindfulness meditation, which is where you sit and focus on a single object or thing, and you use it as a form of trying to disconnect from other things, and it can be calming, and some people find that useful. I have to say, I have tried mindfulness, and I've tried using, and I'm pretty conscientious. I find it really difficult to do mindfulness meditation, but some people who are very conscientious do it. I'm not sure that you actually need to practice the mindfulness meditation. What I do think is really useful is mindful awareness in daily life, and that is getting more switched on. What's going on for me right now? What is happening right now? And that's noticing thoughts, noticing stuff that's sitting in the back of your mind, noticing how you're feeling, noticing emotions, noticing body sensations, noticing tension in the chest, noticing association. So being basically much more present with what's happening, I find that really useful. And actually what I'll do is I'll send you all a mindful awareness exercise, which is just this. So it's not meditation, it's not mindfulness meditation, it's just being switched on to what's happening. There's a little bit of meditation at the end, but it's a really useful tool to just get people to be more present. The third form of mindfulness is mindful acceptance, and I think ultimately that's what we're trying to achieve. It's hard, particularly when people are perceiving high levels of threat, but it's really that attitude of not judging, curiosity, openness, allowing whatever is there, allowing it to be there. And I think when I use mindfulness with clients, it's mainly mindful awareness and mindful acceptance. It's just kind of relaxing into the discomfort. It's taking the risk that whatever is there, I can actually not try and control it. So mindful acceptance, just to give you an idea, it's like it's raining. I don't like the rain. I wish it wasn't raining. My day is ruined. Why does it always have to rain when I want it to be sunny, etc.? So mindful acceptance is, So it's relaxing into the reality of the situation that you find yourself in. And this is a great tool, not just for helping people with dizziness and somatic disorders, but also I think as a tool for living in situations where we can't control, to actually relax into the reality of that situation. We've sometimes referred to it as, this actually is a term that comes from panic surfing, and panic surfing was a term that was developed to help people deal with panic attacks, but we talk about surfing the waves. So the aim is not to stop the symptoms, but to change the way you respond to the symptoms. So you drop the resistance, you don't struggle with or resist the sensations, you let your body do whatever it needs to do. There's a passive acceptance, just let it be, relax into the discomfort. And in a way, it's just surrender. Whatever is there, you just allow yourself to surrender. And people will sometimes say, I'm never going to surrender, I'm not going to let this beat me. But the paradox is, the more you fight it, the more limbic system activation you get, and the more you kind of feed the symptoms, so just allowing, so teaching people to just allow, surrender, and then just return to task. So you don't want to sort of sit there focusing on it forever. You focus on it for a little while and then return to task. I'm just going to pause. Does anyone have a question or anything that you'd like to ask? This comes from what we call panic surfing. So we use the same sort of technique for panic attacks, for people with panic attacks. It's just don't fight it. Let it be, let it happen. And you know, when you sort of reduce that limbic system activation, you get a good response. And actually one of the things I do is practice it with them in session. So I get them to try and just observe the symptoms, stay with it, allow it, and see what happens. And you can actually do that, even medicos can do that.
I don't have a question, but I did have a patient once who had violent Meniere's disease attacks lasting hours.
Yeah.
And he said to me that he just lay down and enjoyed it, went on the ride for several hours,
Yeah,
got through it.
yeah.
He ended up enjoying them.
Yeah, I've actually had, I would have thought Meniere's attacks would be really hard to enjoy, but I've actually had patients who actually do think of it as a carousel ride. And for those who are not aversive to that sort of sensation, it's actually a really useful sensation. And in fact, for some people, they actually can allow themselves to just surrender, go with it. You're surfing, you're experiencing the ride, just let it be. And again, it depends on the individual patient, but some people will respond to that. And I always remind people there's two components here. There's the physical, but there's also the emotional. And when I actually ask people, when you sort of really start coming back down to it, you'll find that the emotional is usually the one that is more disturbing than the physical. So I apportion the suffering. How much of your suffering is physical and how much of it is emotional? So in other words, how much is it anxiety, worrying, frustration, all that sort of emotional stuff that's happening? And rate the level of discomfort of your physical symptoms. So let's try and get an objective number. If we just go purely to the physical symptoms with no emotion, how unpleasant are the physical symptoms and how bad is the emotional distress? And the interesting thing is you will most of the time get much higher scores on the emotional distress than you do on the physical symptoms. It's the fear that becomes the part that dominates this. So we remind people that suffering is a combination of some unpleasant physical symptoms, but at a much greater level, high levels of emotional distress. And maybe, and you can sort of teach people to start, apportioning the suffering. What is the difference? And you can even aggregate the suffering. How much of your day is physical? How much of your day is your physical discomfort severe? When we're purely talking about the physical side. And for some, the actual physical symptoms, whether it's dizziness, wooziness, unsteadiness, or whatever, maybe 10 minutes a day, but they're suffering 100% of the time because they're constantly vigilant, they're constantly living in anticipation that there'll be more symptoms. Try and encourage them to just engage with life now. Don't wait for the symptoms to disappear. Sometimes it's worth just saying, look, they're going to take a while to disappear. I find often it takes a few months. So in the meantime, don't sit there and wait for the symptoms to disappear. Get on with your life now. Set meaningful goals. Think about what's useful to you. What are you interested in? Get on with your life. Get on with focusing on those goals. Try to change your focus from trying to make the symptoms disappear to living your life as fully and as in as interesting way as you can in spite of the symptoms. The symptoms will be there. They might be there in the background. Get on with your life. Focus on your goals. And let's see what happens in 6 weeks' time. And that is useful if they know that they're not going to stop the symptoms in the short term. They become less vigilant to the symptoms. And also, I sort of differentiate between symptoms and functioning. So sometimes people will say, "Oh, I feel terrible. I've got these symptoms," but actually they're functioning at a pretty good level. So there'll be a very small percentage of people who stop working or who can't work. But most people are actually functioning pretty well and achieving most of their performance criteria at work. So that can also be reassuring to point that out. My experience is SSRIs are very often helpful. And there's been a number of trials that have shown that SSRIs reduce limbic system activation, it reduces arousal, it reduces anxiety, and you get a significant reduction in symptoms. Primary symptoms, in just looking at the various studies, primary symptoms reduced by at least half in the majority of people, and in 80% of completers, the primary symptoms reduced. That you also get a reduction in anxiety and depression very often as a side benefit, but high dropout rate, people, and not everyone can tolerate antidepressant medication, unfortunately. Now, this is an area where I know Miriam and I disagree, so I hope you'll bear with me on this one, whether benzodiazepines can ever be useful. I personally think sometimes if they're used very judiciously and they understand the effects, they can be helpful. And just knowing that you've got perhaps a Valium in your pocket, and if you're going to have to perform at work, or if there is something that you're really anxious about, you've always got, there's always something that will help. And benzodiazepines really do help with these symptoms. The fear is always addiction, and that's something we want to stress. So we want to really emphasize that it's just there for emergency use, or sometimes when they're just feeling overwhelmed or depressed and whatever. It can be. I mean, I think even for many people, 2.5 milligrams of Valium is enough to significantly reduce the symptoms and reduce arousal. So I personally think it can be used judiciously for patients who are responsible enough. I don't know if you want to say anything to that, Miriam.
Just the lack of experience, Sarah. I just haven't used it. So it's difficult to say, because I think I have this preconceived fear of addiction, therefore don't use it. You use it a lot in the Meniere's patients who don't have enough symptom control with a vestibular suppressant like Cinarizine or Stemetil. Then I would use it, and I just tell them, don't wait for it to get worse, just hit it hard as soon as it happens. But in Pppd, I've never used it. So
I wouldn't use it for everybody, but for some people I do, and I think it's a really useful drug. As long as they know, look, quite honestly, if they use it twice a week, it's still, I haven't seen anybody addicted, and I've recommended it for a number of people. Most people are very aware that this is potentially addictive, so they are very cautious anyway. And I certainly wouldn't recommend it to someone that I don't believe could use it responsibly. So it's sort of who you recommend it to. But it for many people, just having that pill in their pocket is very reassuring, and can be helpful. So I often just recommend Valium, but I think any of the benzos probably reduce it, as long as you do talk to them about using it judiciously.
Sarah, what's your experience with low-dose tricyclics? Do you find in some people it's anxiolytic, in others it really stirs them up? What do you think?
The tricyclics tend to be more sedating, so they tend to have more of a blunting effect. So I actually think the best one is Lexapro. That's the first one that I would recommend. And yeah, I mean, you could try the tricyclics. I just think the tricyclics have more side effects. So SSRIs tend to affect more serotonin, norepinephrine. You get broader use with the tricyclics. So we normally try and start at the bottom. But yeah, sometimes they don't respond to the SSRIs, so it may be worth trying some of the others. The other one, the one that gets quite often referred to, I'm just trying to think of the name, it's just escaped me. What's the one that you normally recommend when they have tricyclics? It'll come to me now that I'm trying to think about it.
Because the primary disorder the original disorder in many people is vestibular migraine, we tend to start off with something like doxepin or dathiapine. And so that's why we think, oh, well, if it also happens to have a bit of anxiolytic effect.
Oh, I see. But normally it's quite a low dose that it's actually a subclinical dose. Yes, I know now that a lot of them have a subclinical. Yeah, I mean, I know the theory is that it actually may help with the actual condition as well as the dizziness. I guess I'd leave that to your judgment. I mean, I'm not an expert in the, you know, in these areas, but I do have to say lexapro is often well tolerated, not always, and tends to have less side effects. And as you go up the chain, you're often dealing with more side effects. But sometimes I think it's useful. I'm going to go through, I'm just conscious of the time, so I'm just going to go through this very quickly, and it's more probably relevant for the psychologists rather than the other people. So Adrian Wells talked about cognitive attentional syndrome. It's the overthinking, overanalyzing, and many of our patients are doing this. And often they're not even aware, you know, so they're doing lots of worrying, overthinking, overanalyzing. So thoughts feel like the path to a solution. So it feels like if I keep thinking about it, I'll work out how to do it, but actually they become part of the problem. It's the overthinking itself becomes part of the problem. So I might do this exercise because it's such a useful exercise to do. I'm going to get you, I'm going to finish a little bit late, unfortunately. I hope that's all right. And those of you who have to go may need to go. But I want to do this exercise because it's an interesting one. I'm going to get everybody to just sit back, make yourself comfortable and close your eyes. And I want you to think about something that is perhaps at the back of your mind, something, an unresolved fear or worry or concern that you kind of carry there in the background, something that is not quite right in your life. And now I want you to imagine that we have a magic pill that will completely release this fear and this concern from your mind. And this magic pill has no side effects. It's completely harmless in terms of side effects, but all it does is it helps you to let go of this fear and this concern. My question is, would you want to take it? Something that can help you to disconnect from this fear. And when you're ready, you can open your eyes. And I'm wondering how many people would want to take it, or perhaps those of you who'd want to take it, do you want to? You know how to do a thumbs up on Zoom? Just do a thumbs up if you would. You'd happily take it. This probably isn't going to work for you all. Put up your hand. So Sarah's raised her hand. Good. Anyone else? And we've got a few people that are raising hands. Okay, I can see some hands being raised like this. All right, who wouldn't want to take it? Can I hear from those people who wouldn't want or be very reluctant to take this pill, magic pill? Sally, is that a hand for I wouldn't? Sorry,
No, it was a hand from I would.
Oh, you would. Okay, thanks.
Does it expire?
Yeah, it will. It'll disappear. Yep. It's gone. Who wouldn't? And tell me why you wouldn't. Miriam, tell me a little bit about that.
Okay, so what if the fear is something very real, and if I take the pill and I lose awareness of this imminent, let's say, danger, I might not pay enough attention to it in the near future.
So what you're saying is the actual fear is important, and being vigilant to the fear is important because it means that I can monitor it. I guess my question would be, is it possible to problem solve and monitor it without constantly thinking about, without carrying it in the back of your mind with all the physiological effects of that? And sometimes we do need to be conscious of it. I mean, sometimes it serves an evolutionary role, but a lot of the time we're actually, particularly with problem solving, if problem solving is not something you can do, then just carrying it has a physical cost and doesn't actually change change the situation. It doesn't help you to achieve the goal. It just keeps you in an aroused, anxious state. Was there anyone else who could relate to not wanting to take the magic pill that would like to share? Okay. My guess is there would be quite a few, because I normally ask this question in real life. People are very reluctant to kind of totally give up attention to this. And the reason why we're reluctant to give up is very often because of what we call metacognitive beliefs. And that's beliefs about our own thought processes. This is probably a little bit more relevant to psychologists. I'll just go through it very quickly. So it feels like monitoring keeps me safe. It's dangerous to let go of my guard. If I accept the symptoms, I'll suffer forever. This is for people with dizziness. If I believe it's anxiety, I might miss the real cause. If I stop monitoring my symptoms, I'll lose control. The symptoms will never go away. I'll stop caring. I'll stop looking after my health, etc., etc. So these are all examples of what we call metacognitive beliefs. Metacognitive beliefs are beliefs about our own thought processes. So they're beliefs about how I should be thinking or how I should be using my mind. So as long as you have that fear, you tend to go. So we need to address metacognitive beliefs, and that includes identifying and challenging them. And this is going to be for the psychologists more than the rest. So I often ask things like, how would you like to be feeling and thinking? And people are often ambivalent about that. If you could stop thinking about it, would it be a good thing? Could it be risky? Perhaps you believe that if you stop thinking about it, the worst will definitely happen. It feels like that somehow when you're thinking about it, it gives you some control. So I actually do the exercise that we just did with you. I actually do it with a client. And, imagine not thinking about it, imagine being totally free of it. And most of them are incredibly resistant to it. And I sort of say, what's going on? What would stop you from thinking about it? And they say, well, I'll lose control. The symptoms will never go away. I'll miss an important symptom. I'll stop caring about my health. So there's all these thoughts that are about resistance. And so we actually need to address some of those metacognitive beliefs. They're beliefs about our own thinking. I can't change the way I think because there is a danger in doing so. So we challenge the metacognitive beliefs, which I'm not going to have time to do now. I'm happy to supervise the psychologist. If you want me to go through this, I'm very happy to go through it. But we can actually, our job is to actually address the metacognitive beliefs, because as long as on an unconscious level you feel you have to keep monitoring, you will keep monitoring. You'll be motivated to keep monitoring. And this is just a couple of examples. I had a patient who has tinnitus, and I said, what would it be like if you were able to accept that the dizziness will come and go and you just got on with your life, accommodating it as part of your life? What would it be like? And the patient said, oh, that would be awful. Now, can you see that that doesn't make sense? But there's some metacognitive beliefs there, such as I have to be 100% in control of my life. And if I'm not 100% control, I cannot tolerate it. Even if I don't notice the symptoms, I still have to be able to eliminate the symptoms. So that's what we call cognitive rigidity. And another patient who I asked the same question said, I will never accept these symptoms. Everything I've ever achieved in life has always come as a result of hard work. You're telling me to accept these symptoms. And so what are his metacognitive beliefs? The only way I can let go or I can get rid of these symptoms is by focusing on them and working and fighting them directly. And of course, as long as he continues to have those symptoms, those beliefs, he's going to continue to have the symptoms, because by definition, the belief is I have to keep, focused and staying on the symptoms. So he needs a lot of psychoeducation to actually explain the self-perpetuating cycle. The more you focus on it, the more you resist it, the more you fight it, the more you actually perpetuate the existence of these symptoms in your life. So we talk about acceptance. What does it mean and how do you know you're there? And people have all sorts of different definitions of acceptance. And how do you know you're there? Perhaps someone can suggest, how do you know you're there? How do you know that you've achieved acceptance? with anything, I mean, whether it's dizziness or anything else, how do you know that you've achieved acceptance?
And it maybe doesn't become a concern anymore to you.
Yeah, exactly. It stops
It's not in the back of your mind.
It stops sitting in the back of your mind. You stop suffering. You know, so real acceptance is you relax into the reality, or you surrender into the reality, you stop suffering. And one patient said, I actually get it now. It's like the weather. You know, it's like, you know, some days it's going to be wet, some days it's going to be windy, some days it's going to be nice. But you know what, whatever the weather is, I cannot control it. It's just like the weather. And that's a really good definition of acceptance. It's just like, it is what it is. It's not within my control. So just finally, probably 5 more minutes to go, not that long to go. Finally, outcomes. How successful has this approach been? I would say we have a combination of responders, partial responders, and non-responders. I'd say non-responders are very rare. Most people I see will at least partially respond and feel better. Probably, I mean, and again, it'd be interesting to do a study of all the people I've seen and to see where they're at now, some of them years later. But my guess would be responders would be at least 50%, and over time possibly more. But it's worth looking at. This is actually a study that was done of what happens to these people, but it's actually in 2005 when we knew a lot less about PPPD, and it was a retrospective questionnaire, 106 patients, and they had 2 or 3 sessions which were very similar to what we did in our study, which was 2 or 3 sessions, and this was the 2012 sessions, and that was sort of explanation of what's going on, reassurance that this is unpleasant but not harmful, behaviour therapy, getting them to exposure, getting them to stop avoiding places, do regular exercises, normalising it, explaining what's going on, and about half of them had either an SSRI or a Tricyclic. And they did a 5 to 15-year follow-up, depending on treatment. And what they found was half improved. Over a quarter were completely recovered. There was about 3% that was worse and about 22% that was not changed. Now, I reckon with our better understanding now, I reckon our results are much better than that now, but I can't prove it because we haven't done it. But I would, I mean, just at a guess, I would say, that probably more than half have improved. Well, look, I shouldn't guess, but I'd say probably well over 3/4 would be feeling better, and maybe the vast majority are feeling better. There may be some that feel worse temporarily, but I don't think it would be in the long term. And I think we've actually come a long way in terms of understanding the treatment, understanding the importance of mindfulness, understanding, a lot more nuances with these patients. And I think our treatments are better now. Even I think our treatment is better than the 3 sessions that we gave in the study that we did. But the problem is a lot of these people are complex. They have a number of mental health issues, and some of them actually require longer term treatment. So just finally, I just want to say understanding this condition really matters. PPPD is still relatively unexplored and often misunderstood. Many medicos don't recognise and understand it. The GP I spoke to yesterday when we went for a walk had never heard of it, but she said she certainly got dizzy patients she'd love to refer. The DSM doesn't really have a good defining category for this. It's the ISD does, but not the DSM. So it's still not sort of formally recognised. There's not a clear scientific explanation of the biological processes of what exactly is going on. Many patients are extremely impaired, and they've seen neurologists, ENTs, psychiatrists, psychologists, and often without benefit. Patients are often misdiagnosed, and they're taking sometimes quite high-level medications without, unnecessarily and without benefit. And there's a huge financial cost both to the patients and to our health system. There's lots of medical tests, there's GP consultations, specialist consultation. A lot of these people are also doing alternative therapies and having all sorts of other things going on. Effective treatment reduces the symptoms, improves mental state, improves levels of functioning, plus it reduces costs to the health system as people are less going. And it's such an interesting area. It's the interface of psychology and neuroontology. We've got that sort of combination and neurology. It's really, I think, the most interesting area in science because it's really combining the way the mind works with the way the body works. The other final thing I want to say is the brain is plastic, as you all know, and cognitive habits become neurally entrenched over time. And some of the people that I've seen have had this condition for 20 years or more. It is much harder to change neural habits after that sort of period. We want to get patients as early as possible, and early diagnosis and treatment may prevent a lifelong trajectory of disability. So getting that treatment early is really important. And finally, a quote from a paper in Practical Neurology, separating organic from psychogenic is deeply ingrained in our medical system training. Nowhere is it more difficult to separate those than those in patients with chronic dizziness. And as I said, it's a real interface of neurology and biology. Thank you, everybody. I am very happy to stay on if people want. I know some people have to go and I've already gone over time, but I'm very happy to stay on if people want to ask me any specific questions. And what I'll do is stop share. Those of you who need to go, please feel free to go. And I'm just going to stop share. If anyone's got any questions, please feel free to ask.
Sarah, what do you say to the patient who actually says, is it all in my mind?
I would say no, it is 100% in your body. It is definitely physical. You are not imagining this. The symptoms are absolutely real. And that's also stated in the flyer. But psychological factors, or the brain, psychological factors are actually contributing to your symptoms. So we know, for example, that hypervigilance and being very focused on the symptoms is one of the things that maintains the disorder. So this is a very interesting disorder where it's really a combination between physical symptoms but also psychological factors that maintain it. But yeah, they really want reassurance because it actually makes people feel invalidated. And especially if they don't actually get the fact that you're actually saying, no, this is actually very much, it's physical. You're not imagining this. Yeah.
So I don't know, from personal experience of anxiety in me, I would say physical symptoms of anxiety precede the feeling of anxiety. Is that a common thing in your patients, that they feel the somatic symptoms, let's say like chest tightness or lightheadedness, before they're aware of panic?
Yeah, that can be, and it can be partly because there's a biological component as well. So sometimes it may be little bits of, I don't know, crystals in the area of BPPV or other things. So it can be triggered by something that's physical. And this is true when people say, look, I was watching TV. I wasn't thinking about anything. I suddenly got dizziness. And I suspect that may be part of the biological disorder that is triggering it. But once it triggers it, and sometimes the physical thing is only a second or two, but then it triggers the anxiety, which may then be, many hours or sometimes days. So it's really that combination between both.
This is one reason why many of our patients don't believe. They say, but I don't feel anxious.
Yeah.
Very relaxed.
Yeah. Well, the exercise that I suggested is a really useful one, and it's one that you can do, clinicians can do, which is just close your eyes. Just notice what's going on for you. Notice, you might even just say, notice the sensations of your buttocks on the chair. Notice, your shoulders. Now just scan your body, notice your tummy, and scan that area and see if there's any tension or tightness there. Because a lot of people aren't very psychologically aware or psychophysiologically aware. And often when you actually get them to scan, they say, oh yeah, there's a lot of tension there. So actually getting them, the evidence is in the body. They may not be aware that they're anxious, but their body, and if they actually can scan their body and there's no tension, they're not anxious. I'm totally willing to accept that, because you don't have anxiety without physical tension. It's just a totally automatic reaction. Okay, anyone else want to ask it?
I often, this is Nikki, I'm with Miriam. I often say to my patients, you can't live what if. Like you need to, like you can't think ahead that I might get dizzy, I might do that. Is that good to say?
I wouldn't ban it, as in you can't think that way.
No, but like I have patients who, like they won't go, like they won't go outside, they won't do this.
Yeah,
And I say, well, you can't live your life what if.
Yeah. Oh, I see. Yeah. Yeah. I would just gently encourage them to do, and a lot of them do have agoraphobia. So I just gently encourage them to do very small tasks, and that's where that, you know, that sheet, the exposure schedule, where they write down, you know, the task, how long they did it for, and how bad were the symptoms, and they just do it repeatedly. And just start with really small things, and you know, and the main thing is that they'll probably still have symptoms, but they survived, you know, that they managed and they survived and it was okay. So just gradually build up tolerance, and also try and get them, I often try and get them to listen to podcasts, or try and sort of get your brain out of your body, you know, try and focus on things beyond. And I think podcasts are often useful, even though a lot of these people don't want to wear headphones because they worry about their ears. But podcasts, if they're really engaging and interesting things, they can actually disconnect from. Otherwise, if you just say, look at the environment, look at the trees, they do that, but they're still vigilant to body. So it's got to be something that's so engaging that they, you know, that they sort of disconnect from it a little bit. Yeah. And initially, and just do it in a graded way. Go with somebody initially. If you're really fearful, and then sort of gradually, you know, change it. Yeah.
I have patients that won't turn over in bed.
Pardon?
I have patients who have, like, they've got like BPPV and they won't turn over in bed.
But often they've actually been told not to turn over in bed because of the
I tell them now it's time to.
Oh, it's time, and they're still worried. Yeah.
You can't live your life what if, you know, if you turn over, what's going to happen?
Yeah.
Oh.
Yeah, so that's a really classic fear response. If you've had a really bad reaction with something, you tend to then be very, you know, you're sensitized to it. So maybe turn over slowly. And again, that's that graded exposure. Just turn over very slowly and see what happens. And then sort of gradually, as they get more confident, turn over a little bit more. Yeah. Any other questions? Michael?
Hi. I was wondering about interoceptive exposure, like you do with panic disorder, like intentionally bringing on the symptoms and habituating to it. Do you do that here?
I have done that, and because the dizziness, look, maybe I've just done it, but because the dizziness was so unpleasant, and with interoceptive exposure, kind of focus on it, actually kind of backfired a little bit. So I'm a little bit nervous about doing that. I would sort of say more do things that might bring on some dizziness, and just, you know, keep walking, keep thinking about other things. I've had patients, and I've done this a couple of times, where I've got them to just focus on the dizziness and just, you know, just let it be. It's so aversive, you know, that they start feeling sick, and so I'm a little bit nervous about doing that. I mean, maybe with some patients it will work, but I'm a bit reluctant to do that. I'd probably direct them more to just, you know, get on with your life and exercises that way. Anything else? Any other questions? Sarah, you've got your microphone on. I can see you speaking.
Is it off now?
Yeah.
Can you hear me now?
Yes.
Oh, great. Thank you, Sarah. This has been fascinating. What's the demographic of people you see? The gender breakdown, the age range? Do you see it in children? I'm just curious about that.
Very rarely seen children.
Right.
Very rarely seen teenagers even.
Oh, okay.
Would the medicos agree with that? It's probably, yeah, it's older adults generally. And what was the other question?
As well. Young female professionals, very common.
Yeah, yeah. And would you say there's more women than men with this? Yeah, I'd say more women, and I think it's probably because women are more anxious generally. Get anxious.
Or, as Nikki was saying, women will turn up to seek help.
Yeah.
a little more commonly.
Yeah, that's also a factor. But yeah, I definitely see more women. It's so much easier to treat when it's new. You know, if they've had their first dizziness start within the last 6 months, you're much more likely to get a good response than when they've had it for 20 years. So trying to get treatment early, I think, is really important. Any other questions? Did I answer all your questions, Sarah? I can't remember.
Yes, that was terrific. Thank you. Yeah, good.
Yeah. So Sarah, just Miriam, I just want to remind you, Sarah's in Melbourne,
Right.
and her email address is on that list that you would have. You might, because occasionally we do get Melbourne people, and we've got nobody that can.
Sure.
So hopefully, even if you're willing to take on a couple, and I'm happy to supervise any psychologist that wants to do this. I'm very happy to.
Oh, thank you, Sarah. That's very kind. No, I'm very interested. It sounds really good treatment, and like it would really make a big difference to people's lives.
And and it also applies to pain. A lot of this applies to any sort of somatic condition. A lot of, but it's also relevant, I think, to pain management and to and even to tinnitus, which I haven't really talked about much. But the same principles apply. It's learning to accept and sort of get on with things. Yeah. Michael?
Can I just ask something quickly? Just about, you said the patients often don't fall, and that's my real fear, especially with the older adults I see sometimes. I wonder, do you have any advice on how to assess for that? Like, how can I sit with that?
I would actually get advice from Miriam or from the person who refers them. So if they have a balance problem, I would be much more cautious. But if it's not, sometimes it's often perceptual imbalance, but they actually, and in fact, often their balance is good. So I'd still encourage them to go for a walk. I mean, maybe not jogging or something if you're worried or if they're a bit older, but I encourage them to sort of to live their life, to go for a walk, to do some of the exposure. Would you agree with that, Miriam?
I think when we work with a psychologist, we are very much in close communication when we manage the patients, and it should be easy enough for the psychologist to talk to me, talk to Nikki, even talk to the physiotherapist who's looking after the patient. So it's a very tight management plan, and people often talk to each other frequently about person more than once.
And Michael, if you're interested in this area, there is an abundance of people. There is no shortage of people. I mean, Miriam's just one neurologist. I've sort of closed from other neurologists, occasionally accept an additional referral, but there are hundreds of neurologists who would love to refer to you if once you know this area. So it's this can keep you busy for quite a while.
Sounds good, and thanks so much for the talk today. That helped a lot. Really making it quite clear.
Yeah, and Michael and Sally and Sarah, very happy to supervise. Or if you've got some clients, or if you need some help. A lot of, even though I've sort of talked a lot about a whole lot of different things. Initially, you just focus on one or two things. You kind of get better, or you sort of work it out a little bit more as you go on. And just email me or call me for advice.
Thanks.
Thank you so much, Sarah.
All right, and for others, I hope, and even people who are not psychologists, some of the stuff hopefully that we talked about, you may still be able to apply and use with patients.
Thanks, it was very great.
Thank you, everybody.
Thank you.
Thank you very much.
Stop recording.
Thank you.
And make sure that I'll work out how to do all the technology. All the best, everybody. Thank you.
Thank you so much. Thank you so much, Sarah.
Thank you very much.
Okay, bye.
It was terrific. Bye, everyone.
Bye.
Thank you.